talk about the Joint Commission guidelines. Now, why is this important? Because Joint Commission is going to require every hospital to follow these guidelines. And so if you do obstetrics in any place in the United States, these are going to be the guidelines that you will need to follow in order to provide appropriate care for your patients and to pass that all-important Joint Commission survey. Everybody put your cups up. Because you know, at Joint Commission, you can't have cups. So, so what are these measures? These measures of any industrialized country. And if you happen to be an African-American woman of high risk, i.e. over the age of 40, you can deliver in many other countries, third world, and have a better outcome. We must do better. And so this is Joint Commission's way of making us address the maternal issues in the hospital. Because, you know, everybody thinks we're down on labor delivery singing zippity-doo-dah, my oh my, what a wonderful day, and nothing ever bad happens down there. But because of that, there has been a lack of attention and focus on what protocols and things that we can have in place to do a better job taking care of our patients. The two things that this measure is going to emphasize is hypertension and hemorrhage. And I think it's really important to know that in the state of Tennessee, Tennessee ranks 43rd in the United States in maternal deaths. When we reviewed our deaths, our pregnancy-related deaths in 2017 to 2018, 100% of our deaths, 66% of our deaths, 2/3 were felt to be preventable. And how we do better is why you're here today, to talk about simulation and how to implement that into taking better care of patients. So, what are the issues that these guidelines are trying to address? The first is inadequate resources and personnel. Now, we talked about low resource and high resource hospitals, but anybody who's ever worked in a hospital knows that many times even high resource hospitals don't have any resources, or the resources have been used up. So how do we make sure that we have resources available? What type of system do we have in place to make sure that they're there? And what about our personnel? We may have personnel in place, but do they all work together? Or in a unit where I come from, where there's, what, 200 labor and delivery nurses, Sherry? Do we even know each other? Have I ever seen you when this emergency is taking place? Did we prepare for hemorrhage on admission? Or did we have a protocol to recognize hypertension? Or did we just wing it? We just, like I said, think that nothing bad was going to happen on labor and delivery. Now, we all know that pregnant women bleed. I was doing a procredo with one of my GYN oncologists, and I delivered the baby, and this blood was coming out. She goes, Connie, she's bleeding. I'm like, yeah, this is called a C-section. Remember that when you were trained in OB? Because we're used to a lot of blood loss. And because we're used to a lot of blood loss, we may underestimate what that blood loss may be. Then that leads to delay because we minimize it. We're like, oh, no, she's not bleeding. No, I think the bleeding's going to stop in a minute. Oh, it's going to be okay. And so because of that, we don't have any of the types of things that we were going to initiate are not initiated in a timely fashion. So we have a delay in treatment of our hemorrhage or delay in treatment of our high blood pressure. My favorite for high blood pressure, she was in pain. She was breastfeeding. Well, great. Oxytocin should lower your blood pressure. You know, she's in labor, yes, but not every pressure should be high. So those are the things we have to take a look at to make sure that we're providing adequate treatment. And then what do we do when treatment fails? How do we go to that next step? How do we simulate when that patient hemorrhages and she needs a hysterectomy and she's only 18 years old and this is her first baby? How do we remove the emotion from that and make a rational, objective decision about what is in the best interest of that patient? In the EP1 studies, the first thing we're going to do is assess and discuss hemorrhage during the antepartum period, the intrapartum period, and the postpartum period. That's really important because hemorrhage risks change. The antepartum risk, this is going to be she's a 37-year-old, gravida 5, para 4 with a previa. Is she at risk for hemorrhage? What about the 25-year-old gravida 5, para 4 with twins? Is she at risk for hemorrhage? Yes. Or what about the gravida 8, para 7, now with triplets? Anybody watch that show where the woman keeps on having multiple births? Yeah. Does anybody think that she's at risk for hemorrhage? And so we need to prepare. That's an antepartum. That's an antepartum assessment. But then intrapartum, that same patient who's a gravida 1 now is on MAG. Now that changes her hemorrhage risk. And postpartum. When she goes to the postpartum floor, just because the baby's out doesn't mean everything is all good. We can just go hallelujah and leave her over there. So we have to be able to assess that at all times. And there's an evidence-based tool that has an algorithm to identify hemorrhage. There's a use of this evidence-based order set that we use to treat hemorrhage. It should not be, well, Dr. Graves likes this, and Dr. Lister likes this. And you know, when Dr. Garrison's here, we have to have this. And when Dr. Tate's here, we need this. Because when we do those types of variations, it means that the team has to change every time and try to remember what I like. And guess what? Dr. Lister and I traded calls, so now you prepared for me, but she wants something else. So there's that we have to have an evidence-based set. The response team and their roles, like who's doing what and how do we activate it. When we call a code, we have an OB rapid response code. Who comes? Do they come? When do they come? How do they respond? This is the hemorrhage assessment tool. This is low risk and no previous uterine incision, singleton pregnancy, less than 4 births, no bleeding disorder, no evidence of postpartum hemorrhage. Those patients can get a clot tube. Most of our patients fall in the medium risk category, however, because in Tennessee, one of the things on here is probably 70% of our patients, and that's a BMI greater than 35. That increases your risk of having hemorrhage. Multiple gestations, induction, that's the other thing. So now we have a patient with a BMI of greater than 35, and we decided to induce her. Guess where that moves her to? The high risk category. So here we are at the high risk category, and so she has a placenta accreta, procreta. See, we're good at that. I know how to plan for those. We have a multidisciplinary conference. Everybody's all on board for those types of patients. But then, what about the patient who had a hematocrit less than 30? Did we plan for her too? Or platelet count less than 100,000? So this is kind of the risk assessment tool that you're going to need, and everybody needs to communicate the same. Dr. Graves, I obtained a type and cross on your patient because she is high risk. Her hematocrit this morning is 28. Maybe you should have considered iron, but no, we'll go back and talk about that later. She is morbidly obese, and she is being induced. Blood bank. So if you're in a smaller hospital with lower resources, that high risk patient's on your unit. So have you alerted your blood bank to know, hey, how many units of blood do we have? I need everybody to go back and find out how many units of blood you have on your unit in your hospital. How many units of blood do we have? Because we have a high-risk patient for hemorrhage today in our hospital. How do we release it? How do we initiate the massive transfusion procedures? So I'm going to tell on myself. So we initiated massive transfusion at St. Thomas Midtown. I thought it was all good. I went to the blood bank. We had it together. We initiated in 2009. Guess what? I did an amniotic fluid embolism, and the patient survived, and I went to the adult ICU, and I ordered for more cryo. You know what they said? You need to put those orders in. I was like, wait, she's on the massive transfusion protocol. But what the hospital, she was only in their mind on the massive transfusion protocol when she was on labor and delivery. When we moved that patient to the ICU, then the massive transfusion protocol fell off. So what happened? We went back to our medical executive committee and made it hospital-wide. See, those are the types of things you learn in simulation and in taking care of patients. What are your additional experts? Where are they? Are your additional experts on site? Or do you have to call them? I do teleconferences, like with one of our sister hospitals, Rutherford. You can get me on the phone. I can look at the patient. What do we do to make sure that when do we transfer to a high level of care? Should we really deliver that accreta in our hospital when we only have 20 units of blood available? Things to think about. How to communicate to the family and the patient during and after the event. Miss Jones, you cannot deliver at your community hospital. We love you and we'd love to keep you here, but this is not the place for you to deliver. And the patient says, but I plan to have, a water birth, and what do you mean I need to have a C-section? What do you mean I have to leave my hometown? That's a conversation that often we don't do well with our patients. And so then the patient is angry because she can't have her birth there. So how do we do that? That's part of this process as well. And then if we have a critical event, how do we talk to her afterwards? And as the first team talked about, what is debriefing? How do we immediately after a case of severe hemorrhage, what went well? What didn't go so well? I had a case of severe hemorrhage, and I had to raise my voice in the OR, which I hate to do. Anybody who's ever worked with me in emergency knows my voice, Scott's voice goes up an octave. My voice comes down. I'm like, and I start being really polite. I need blood, please. And Sherry's over here laughing at me. Can you get for this for me, please? No, ma'am. I'm going to stay on the unit. Please, I need you to go run and do this. So when my voice goes down like that, so in the middle of the OR, I was trying to talk to the senior anesthesiologist, and I had to say, I need everybody to be quiet, which is unlike me. But I couldn't hear. So how do we simulate that again so I don't have to raise my voice? This is the hemorrhage protocol. I hope you have it in your operating room and in your rooms. Stage 0. Stage 1 is after you've lost 500 cc's. For vaginal, 1,000 for a C-section. You should be activating your hemorrhage protocol. Do you have TXA on your unit? Do we need to go get that? Stage 2, actively managing these, and stage 3. In addition to that, you should have at stage 0 actively managed your second stage of labor. Each unit has a standardized, dedicated hemorrhage cart with supplies and approved procedures to the response, and the cart is stocked after you use it. Anybody ever gone to the cart and something you thought it was on there, and when something wasn't stocked on there? Yeah, that doesn't work very well. And then last but not least, role-specific education on all patients who treat patients with a hemorrhage. At orientation, anytime the process changes, and every 2 years. We should be educating. And that's what simulation can do. Because in the simulation, I can say, well, you know what? I want to use Valium. And you can say, there, Dr. Graves, ACOG just changed the protocol. And, maybe would you like to consider something else? And so that's a good way to teach without being in a non-threatening manner. Conduct drills once a year. So what you're doing here is to take back to your hospital so you can meet these requirements. And then the drill should include all disciplines. Blood bank, if you use the ICU, who responds at night. Everybody who is going to take care of your patient. And then you're going to review cases based on established criteria. So that if the patient bled and she had a stage 4 hemorrhage, how did she get here? Did we do everything right? Was this unavoidable? Because sometimes it is. Or maybe we should have seen this when we did our hemorrhage assessment and we just didn't recognize it. And then to provide education to patient and families, signs and symptoms of postpartum bleeding, including intra-abdominal bleeding, and when to seek care. And I'm going to stop a few moments just to give a shout out to the post-birth warning signs. This does come in 5 languages, so you'll be able to give this to your patients. And this actually looks at every type of postpartum complication, because we often send patients home with how to resuscitate your baby, how to take care of your baby, how to breastfeed your baby, what to do when you have problems, but we don't do very much maternal education. This is that opportunity, and it's an algorithm so the patient can go, oh, my leg is really swollen, maybe I need to come on back in. Now this is the O3 measure. The first one was the O1 measure. This is to reduce the likelihood of harm related to severe hypertension. Again, the same things. Develop an evidence-based procedures for measuring and remeasuring blood pressure on your unit. And for defining severe hypertension. How many of you have a manual cuff on your unit? 1, 2. I asked for one day, and they looked at me like, manual cuff? I thought I'd asked for gold, actually. And then keep in mind that the patient does not need to be on her left side. The patient should be seated or sitting up in the bed, 5 to 10 minutes preferably. I always love it when people have driven in Nashville traffic and my MA comes to tell me her blood pressure is high. Yes, my blood pressure was high this morning too. Just give her a few moments to settle out. You want to do 3, with the manual cuff, 3 pressures. First and last quarter cuff sound. And then you want to do, like I said, 2 additional readings 1 minute apart, and then record the highest reading. And if it's 140/90 or greater, then you need to repeat in 30 minutes. If it's still elevated, you need to evaluate the patient for preeclampsia. Patients do not need to be positioned to either side. It's not an accurate blood pressure. And actually, if you know the history of preeclampsia, it is the rollover test, and it is diagnostic of preeclampsia when your pressure goes down when you roll the patient over. So when you're sending that patient out the left side, and have you ever seen anybody going out like this? So that becomes kind of a hard thing to do. Then you want to develop these evidence-based procedures for managing the pregnant and postpartum patient with severe hypertension. So St. Thomas Midtown has had their guidelines in since 2012. You know what I did? I took the ACOG technical bulletin and I made it an order set. That's it. I didn't do anything special, but you can definitely do that. And you want to know, hey, are these medications stocked on your unit? One of the things we found out was they were stocked in labor and delivery, which is great, but we have 23 beds, which means that somebody has to run from the 21-bed antepartum unit, and it's almost a half a mile around there. And so I was like, well, these medications need to be stocked in antepartum. And then our postpartum floor is on the 7th floor. Well, does L&D need to get on the elevator and run up to the 7th floor to give out medications? Absolutely not. So these medications need to be stocked on postpartum. And so we have to make sure that they're readily available. The use of seizure prophylaxis, where your consultants. When does the patient get continuous monitoring? When does she move from antepartum to labor and delivery? When does she get a C-section, emergent delivery? And when do we debrief? And here's the committee opinion. This is the emergent therapy for the acute severe hypertension during pregnancy and the postpartum period. Blood pressure 160. 2 readings 15 minutes apart within 1 hour, or diastolic 2 minutes, 2 readings 110 milligrams of mercury or greater apart within 1 hour. And the reason you need to do this in 1 hour is the patient comes in, her blood pressure is 180 over 120. Well, what do we know about preeclampsia? It's a vasospastic disease, right? So 15 minutes later, her blood pressure is what? Normal. And we're like, yes, let's take the blood pressure cuff off. But the problem is, then the 15 minutes later, what's her blood pressure again? Yeah, it's high, right? It's back to that 180 over 120. So that's why the hour is important, because if you don't, you may miss a diagnosis because this is a vasospastic disease. You want to prevent end organ damage through treatment, avoid a seizure, and you want to diagnose this and treat it within 30 to 60 minutes. That's why that's the hour. Blood pressure returning to normal should not be the goal. Our goal is to get that blood pressure out of stroke range, 160 or greater, 110 or greater. Magnesium is the drug of choice, and it's 4 to 6 grams followed by 2 grams. The only time you need to be worried about magnesium maintenance is when the patient has renal failure. Then you can bolus them and let's leave the maintenance off. Now, why is magnesium important? Because it prevents seizure. Studies, trials have shown that it's superior to everything else in the prevention of seizure. And for preterm babies, while we're talking about helping out the NICU, it also is a neuroprophylaxis to prevent cerebral palsy. So starting MAG is not a bad thing. Now, the problem is a lot of times we don't want to start MAG, right? Because we think it slows down labor, for whatever that reason. I always tell doctors, yes, so does seizure when you have to attend to it. So therefore, if you're thinking about it, you need to think about it in those terms, but magnesium needs to be started. These are those standardized order sets. When we look labetalol, the one thing I want you to keep in mind about these order sets is the difference in which you treat. Labetalol is every 10 minutes, 20, 40, every 10 minutes. Then we go to hydralazine and we move to every 20 minutes. So it's a difference in monitoring. Same thing with hydralazine is every 20 minutes. You move to labetalol, you're back to every 10 minutes. And then you need to follow up every 10 minutes for an hour, every 15 minutes for an hour, every 30 minutes for an hour, and then every 4 hours, once you've gotten your blood pressure stable. Nifedipine is my favorite. You can use it on postpartum. You don't have to have an IV. You can use it when you can't get an IV. As we know, getting an IV in these patients can be very difficult. And so therefore, it's one of my favorites. And you can use it directly, orally, and then every 10 minutes, every 20 minutes. And I will tell you, in my opinion, it works better often than many of the other choices that we have. Again, we need staff-specific education and that same time. And what we tell people, this is how, our hospital does it. When you come, these are our protocols. This is how we do it. This is evidence-based medicine. This is based on ACOG and A1, and this is how we do it. Conduct drills at least once a year in hypertension, which we're going to be doing today. Again, all disciplines. What happens? Does your patient go to the ICU after she's delivered and she's hypertensive? Does she stay in your labor and delivery? Or does she move to antepartum? Each placemate is unit specific, but you should have a protocol for what happens. And you need to review hypertensive cases. We had to do this. We had a patient who had a stroke in one of our hospitals, and you can see when we talk about that tunnel vision, that loss of awareness, the patient was laboring, but everybody forgot that her blood pressure was high for almost 2 hours. So it's important for us to remember that when we're taking care of these patients. So over time, over 2 hours, her pressure never came back down to normal. But everybody was worried, she was laboring, and so they kept on readjusting the cuff. You can see the process, but there was this loss of sensory awareness that, hey, now this patient's been hypertensive for so long. So once we do that, how do we debrief this? How do we say, hey, these are the guidelines? How do we say, how do we have emotional safety in the debriefing? And that leads to my last comment. Well, I have 3 phases. The reaction phase. I don't think there's any one of us who wants something bad to happen. So it always makes us, really stressed. One of the things we had, whenever we have a death on the unit, which, in a level 4 hospital, you're going to have on occasion. One of the first things I do is I never debrief on that day. I always just make sure that the staff is okay. We had an amniotic fluid embolus. The patient didn't make it. Is the staff okay? Because, that is what really needs to be attended to. So that's that experience and impact phase. And then, how did you feel? How did you feel we performed as a team? Then you can go to the recollection phase. What happened? What was done well? What could have been done better? And then last but not least, if we don't think everything went perfectly, how can we do that better next time? It won't change this outcome, but how can we change future outcomes? Again, we want to provide education to patients and families. This is really important, especially if you're going to manage your preeclampsia as an outpatient. Signs and symptoms of severe hypertension at discharge, when to follow up for an appointment. Twice weekly testing, usually in the antepartum period, especially if the patient is greater than 28 weeks, and within 1 week if the patient is postpartum. Do you have anything in your hospital that allows you to do that? Make sure that your doctor makes that appointment. Because we're busy and we forget. So what is the process in your hospital to make sure that happens? This is another good resource for giving to patients to allow them to be able to express to doctors and to know when to come back and to recognize their symptoms as serious. It's called the Hear Her campaign, Hear Her Concerns. You can go on the CDC website, and it has really great pictures and information for making sure our patients come back and that they're heard when they come back to see us. These guidelines will be required for all hospitals delivering obstetrical care. Right now, the focus will be on hypertension and hemorrhage, and the goals are really to improve care through standardization and through multidisciplinary teamwork and continuous quality improvement. And that's why we're here today. Thank you for your time and attention.